Welcome to this clinical deep dive. If you're a second-year medical student currently tackling your medical pharmacology course, you are in the exact right place today.
Yeah, it's great to have you joining us.
Our mission today is to help you master the principles of rheumatoid arthritis pharmacotherapy, and we're going to do that by unpacking a real-world clinical case study.
Right, using actual patient case files and the current rheumatology pharmacology guidelines.
Exactly. So let's just unpack this right away. I want to introduce you to our patient. Her name is Helen.
Okay, let's hear about Helen.
So she's a 42-year-old registered nurse, and her social history shows she's been a pack-a-day smoker for, the last 20 years.
That's a huge environmental risk factor right there.
Right. And she presented to the clinic with symmetric polyarthritis in her hands, wrists, and feet, plus morning stiffness that lasts well over an hour.
And her physical exam actually revealed subcutaneous nodules on her forearms as well.
Yeah, which is a classic sign. So we ran her labs, and they definitely show active systemic inflammation. Her ESR and CRP are significantly elevated.
But the real smoking gun for aggressive seropositive RA comes from her autoantibodies.
The anti-CCP, right?
Exactly. She has a highly specific positive anti-CCP of 94 units and a positive rheumatoid factor at a 1 to 300 dilution.
So with those inflammatory markers just absolutely sky high, are we jumping straight to standard DMRs?
Well, not quite yet. What's fascinating here is we have to look at her baseline metabolic panel first.
Which showed her BUN, serum creatinine, and liver enzymes are all perfectly normal.
Right, and while checking those baseline labs might seem like just a mundane detail for you to check off, confirming normal organ function is a strict, mandatory step.
Because of the potential drug toxicity.
Exactly. We absolutely cannot initiate DMARD therapy if a patient has underlying liver disease or severe kidney impairment.
Got it. But since Helen's metabolic panel is clean, that gives us the green light.
It does. So we initiate the treat-to-target strategy.
Using the Clinical Disease Activity Index, or CDAI, to establish our baseline.
Right, and then she's prescribed oral methotrexate, MTX, along with a folic acid supplement.
The classic anchor non-biologic DMARD.
It is the first-line defense for a very good reason. The mechanism of action for low-dose MTX is just brilliant.
It inhibits nucleotide synthesis, right?
Yeah, which causes a spillover of cellular ATP and ADP. And out in the extracellular space, that rapidly gets converted to adenosine.
Which acts as a molecular brake pedal.
Exactly. It basically forces a cellular stand-down of the immune response.
But MTX has a notoriously slow onset. I mean, it takes weeks or even months to really kick in.
Yeah, it does. So we use bridging therapy. Helen is given low-dose oral prednisone.
A corticosteroid for rapid symptomatic relief.
Right. It's crucial for her quality of life while we wait for the MTX to reach therapeutic efficacy.
Okay, so let's fast forward a bit. At her 3-month follow-up, Helen's CDAI score hasn't reached our target, so her MTX dosage is maximized.
And then 6 months in, she is still suffering from severe pain. Her CRP remains elevated, and x-rays show progressive joint damage.
Here's where it gets really interesting. What is the protocol when the anchor drug just isn't enough? Do we scrap the methotrexate and try something else?
We definitely don't throw it out. Instead, we step up the therapy.
By adding a biologic DMARD to the regimen?
Yes, but first she has to have a negative TB test.
Because biologics significantly increase the risk of serious opportunistic infections.
Precisely. So once she clears that hurdle, she's prescribed adalimumab.
That's a TNF-alpha inhibitor administered via subcutaneous injection.
You got it. So now she's taking both the maximum tolerated dose of MTX and the new biologic simultaneously.
That synergy is really fascinating to me.
If we connect this to the bigger picture, keeping MTX as the anchor makes perfect sense.
Why is that?
Well, biologics like adalimumab are large, complex proteins.
So the immune system can recognize them as foreign.
Exactly, and it forms neutralizing anti-drug antibodies, which leads to treatment failure.
Oh, I see. But the MTX suppresses the early expansion of T and B cells just enough to prevent the body from forming those anti-drug antibodies.
Right. MTX is basically acting as a bodyguard for the biologic.
Dramatically extending the drug's lifespan and clinical efficacy.
It's an incredible combination.
So what does this all mean for you, the student? Helen's case perfectly demonstrates the aggressive, step-up pharmacological progression that's required to halt irreversible joint destruction.
Yeah, you aren't just treating the pain. You have to aggressively suppress the underlying immune dysfunction.
Which brings us to the end of today's deep dive. But we want to leave you with an important question to ponder as you continue your clinical pharmacology studies.
We know that an environmental trigger like smoking leads to the citrullination of proteins in the lungs.
Right.
But why exactly does the body's resulting loss of immune tolerance to those proteins localize its destructive inflammation so specifically within the synovial joints?
It's a really fascinating mystery of pathophysiology to explore on your own.